Okay, what's new? How's everybody doing? Good?
Anxious
About
everything.
everything in life?
Yeah.
We have some behavior issues, some nervous anxiety over here. Did you figure out the source of that? Contemplate on it?
Whether or not I want to continue with psychology in grad school or just go get an MFA in creative writing.
Interesting. That could cause some anxiety. What's the rationale between switching? Possibly.
Just, I like psychology, I find it interesting and everything, but I know that like my true like passion, what I really enjoy doing is writing.
Just right. Yeah. I say go at your passion, right? If you're gonna be doing something for the next 20, 30 years for the most part, always stick with what you like doing. I feel like you'll be stimulated a lot longer. I think you'll be stimulated with psychology, but maybe creative writing a lot further. And then think of utility, right? Think of, hey, which one will be most impactful to most people, right? And maybe it could be for you writing, right? If that's a thing, if that's something you care about, you want to make an impact somewhere. Anyone else? Anxieties, issues, good stuff. All right, we're gonna talk about some diagnostic issues. We'll talk about cultural diversity, cultural competency, insurance reimbursement, how this all kind of looks like once you get into the field as a practitioner. And so you could be well versed on what to expect, all right? So we know that we have to follow the Diagnostic Statistical Manual, right, the DSM-5 for the most part, in order to diagnose properly a disorder of some sort. Now this is important because of all sorts of reasons. We know that there could be potential issues with labeling people improperly. Those can have negative consequences to their lives. They can have a fixation on that label. Others can ostracize, stigmatize them because of those labels. So we have to be very, very conscious and sensitive to how we're going to apply labels to a human being who may have some behavioral issues or possibly disordered in some way. So the medical and health professions take this very seriously because they know the consequences. The other part too is for insurance companies. So insurance companies typically want to reimburse when only there's a diagnosis provided, right? So we say, hey, it's a little bit more trickier if you're just doing an analysis or an assessment because some insurance companies may not reimburse for that. So therefore you can run into some financial issues, right? Either for the client or for yourself or your organization that you work for, the hospital that you work for, the facility, what have you. Human service practitioners frequently encounter clients who lack effective problem-solving skills or complain about unmanageable anxiety or depression, right? We say this is something that's not enough to diagnose. We will write this down in our notes and maybe do some assessments for a week or two. And we come about to these conclusions. We say, still, this is not enough to diagnose someone with generalized anxiety disorder, major depressive disorder, single episode, severe, or it could be, right? If they met the criteria, because there's a lot of standard criteria for such. So let's see, generalized anxiety disorder. Let's see if we can look up what the criteria is for that. All right, so have someone here complain about anxiety for a second, right? And we wanted to understand, well, what does the DSM feel about anxiety? Could it be a disorder of some sort? Or could it just be you're just going through some situations, you're thinking about some things, right? You have to make some critical decisions in a short period of time. Maybe some other stuff in your life is causing some sort of neuroticism, right? You're overthinking about things also. Let's see what the DSM-5 says about it. Excessive anxiety and worry, apprehensive expectation. So you have apprehensive expectations about whether to go into psychology or creative writing, get an MFA or continue with psychology. Occurring more days than not for at least 6 months. That's something you have to really think about. Has it occurred more days than not? Maybe look at the average within a week. Like, how much have I thought about this from Sunday through Saturday? About a number of events or activities such as work or school performance. So it could be related, right? The person finds it difficult to control the worry. Is that a symptom that you're experiencing?
Yeah.
Difficult to control the worry itself. Okay. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms present for more days than not for the past 6 months. Restlessness, or feeling keyed up or on edge. Yes or no?
Yeah, I've had trouble sleeping the last couple days.
Being easily fatigued.
Sure.
Right, a little bit of uncertain about that, right? But not too sure, right? Didn't come off as immediately a yes. Good thing, right? Difficulty concentrating or mind going blank.
Yeah.
Yeah, mind goes blank or just a difficulty concentrating? Gotcha. Irritability. Are you irritable? No. Okay. Muscle tension. No muscle tension. Sleep disturbance or difficulty falling or staying asleep or restless, unsatisfying sleep.
Yeah.
Okay. So they say maybe, sure, you meet the criteria for at least 3 or more of these symptoms. Okay, let's go a little bit further. The focus of the anxiety and worry is not confined to features of an Axis 1 disorder. The anxiety or worry is not about having a panic attack. A panic attack is a panic disorder, being embarrassed in public, being contaminated, obsessive compulsive disorder, being away from home. So you don't appear to have that, right? There's nothing to do with that. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functions. Sure, you meet the criteria. This disturbance is not due to the direct physiological effects of a substance, no, right? Or general medical condition, right? No medical condition, you're not, no outward substance or anything. You sure about that? Let's see.
No, I don't.
This disturbance is not better explained by another mental disorder, such as negative evaluation and social anxiety disorder, social phobia, contamination, or obsessive compulsive.
I do have that. I do have contamination and obsessive compulsive.
So you did. Okay, so now we've identified some other relative associations. You know, we have to investigate a little bit further. There's some linkage to how you currently feel about these critical decisions you have to make versus the OCD as their connection between the neurotic behavior, fixation of thoughts about things, right? Let's see, separation from attachment. Probably not, right? No separation anxiety. Reminders of traumatic events and post-traumatic stress disorder. OCD is not connected to anything dealing with the past. Just maybe
That's
something that.
really annoying actually, because there's no real reason that I have that.
Gotcha. Reminders of traumatic events, okay, gaining weight in anorexia nervosa, probably not. Physical complaints and somatic symptom disorder. No, you're probably not complaining about physical things wrong with you, right? Having a serious illness or illness and anxiety disorder, no. Or the content of delusional beliefs and schizophrenia delusional, no. E, the disturbance is now attributable to the physiological effects of a substance, no. That's not it, or a medical condition. So could we diagnose? I don't know, we probably couldn't, right? We need a lot more information. We probably need to really look at that association between OCD, right? Because we sound like, hey, what's the struggle with two competing choices? The struggle may be overthinking, fixation on things about those things, maybe fixation on yourself, maybe on how great you're gonna be doing either. So you could possibly be ego-driven, ego towards your personal success, where you're gonna ultimately be in life. We can go further deeper, right? So we say it's complicated. It's not something simple as reading in a book where you need time, a lot of time, right? Okay, so we can't say it's general anxiety or OCD. We have to say, let's investigate a little bit further. Right? But yes, you will run through like, hey, okay, I meet 3 or more of the criteria. Interesting, mild, moderate, severe. We have to figure out the degree to which, right? How often is it happening, recurring? So we say it requires some very, very thoughtful circumstances and a lot of length of time. Okay. All right, insurance. Most practitioners and insurance companies rely heavy on the DSM and its categories to identify client problems. So the insurance companies want things to be codified. They want things to be coded. They don't want loosey-goosey assessment and analysis in order for them to be paying out money, working with professionals, right, in this field. So we have to be very keen and use the DSM and the DSM-5 only, which we'll later see there's some critiques about there. There's some critics to that, right? Which said the DSM doesn't really tell the true story and have a ton of flaws in it. All right, insurance companies reimburse practitioners based on DSM-5 diagnosis. It says not necessarily for these functional behavioral assessments we're doing or analysis. Probably won't get reimbursed for that. You have to pay out of pocket. That could pose an issue for clients if they can't afford that, if they don't have out-of-pocket money. And so we could have to work with some other sort of resources and direct them to that in order to satisfy their issues. Medicare, Centers for Medicare, reimburse behavioral practitioners, including social workers, psychologists, and psychiatrists, according to the ICD-10, which uses corresponding codes with DSM-5. And anyone here familiar with the ICD-10 or the ICD itself? Anyone here has heard of ICD?
That's what they use in Europe, right?
That's what we use globally, right?
Mostly.
So yeah.
Everywhere
Europe.
Sorry, I was thinking Europe, but
No, but I mean, you're right, because
everywhere not in the US.
Yeah.
Like the metric system.
But Europe would be sort of a fair assessment because we say it particularly deals with the United Nations, right? And we're looking at things particularly out of Switzerland and things with the headquarters there. But the headquarters would be in Geneva, right? We're looking at international classification of diseases. So like when we have something that crosses borders, like COVID, we're not looking at the DSM-5. We're not looking at maybe American medical textbook things. We're looking at what the ICD-10 says, right? Some sort of unified or uniform international classification of every disease imaginable, right? Things we understand globally. So yes, when we experience COVID, usually we're hearing information about the international community according to the ICD-10. Right? But here we're talking about ICD-10 also covers mental health issues, right? Mental health disorders, psychological disorders. And they use codes which correspond to DSM-5 diagnoses. So they kind of go together, they work together in terms of coding for mental health. DSM and ICD familiarity. Thus, in order for practitioners to be reimbursed for their services, it's necessary for them to be familiar with the DSM-5 ICD has been used in many decades to provide measures of national and international comparability in public health. These things are constantly being updated. The DSM-5 is being revised and updated as we speak, so is the ICD-10. You can find some of this information online at the appropriate websites. Now, non-disordered condition in the DSM-5, psychosocial and environmental stressors are listed with mental disorders and physical health issues using expanded set of Z codes, which are considered non-disordered conditions, right? These conditions are sometimes focused of treatment that involve a diverse range of psychosocial and environmental issues. So we think of there's things out there that are really non-disordered. There's just things that people are dealing with as a cause of their environment or other people is affecting them. And we have to really kind of address those too, and there's different codes for those, right? There's a whole different set of codes. So we could think of things like child abuse, right? Child abuse is a thing that has non-disordered, it's a physical abuse of a child, but it still needs to be remedied. And think of the outcomes of that. And so we'll use specific codes for child abuse. We use specific codes for partner distress, domestic violence, or things that spawn from that, right? Different codes for homelessness. We say, well, these are non-disordered sort of circumstance, but it's still something that impacts your daily life and probably your mentality on a daily basis. So they have their own codes for homelessness. Occupational difficulties. Think of the amount of things going through your mind if you can't find a job with a degree from Concordia University. Right? You may not be experiencing a mental disorder, something prolonged, but you say, well, in an immediate time frame, this really causes me a lot of distress. Right? My mind can't focus. Problem with housing and finances. Very common amongst married people or people in some sort of cohabitation environment, struggling together, especially with children, for housing and finances. Not a mental disorder, right? But definitely one that causes social distress, environmental stress. Acculturation, think of the migrants, right? We have the migrants here in Chicago. What sort of issues are they going through with acculturating? Trying to adjust to American standards. Chicago culture for that, Chicago population. Language barrier, right? Lack of finances, how creative are they going to try to be to make money for themselves on a daily basis, right? Being that they have no true status here, may not have a social security card. All these different things. Legal issues, right? We think of the amount of distress going on with if you are accused of a crime and may face some huge fine, penalty, or imprisonment, and other personal circumstances, right? So maybe we could say, hey, making a tough decision between an MFA and getting a master's in psychology or a PhD could just be a personal circumstance. Nothing more, nothing less, non-disorder. Just making personal circumstances like the rest of us, right? No different. All right, Z codes. The expanded use of Z codes have been viewed as a way to maintain social work, psychosocial perspective in a diagnostics process. For those of you seeking social work, who here is attempting to be a social worker or looking to be a social worker as opposed to quote unquote psychologist? None of you? All right, so you think of social work like you're really helping people deal with these types of things. Maybe they're not really experiencing a disorder, which as psychologists we would treat, but they're experiencing like, man, I need a job. I need some housing. I'm homeless, right? I need some rent vouchers, right? I need to get back to school and get trained. I need some skills. I'm experiencing domestic abuse, verbal abuse, physical abuse. I'm experiencing some social and environmental things that the average person may not be experiencing. Can you please help me out? I need your assistance. The Z codes will be quite useful for those in Masters of Social Work or social workers to help in their sort of process, right? Diagnosis with Z codes may not be reimbursed by insurance companies or Medicare. So that's quite unfortunate. So people, unless you have a formal diagnosis from the DSM, even here with Z codes, when we're looking at homelessness, abuse, child abuse, we say insurance companies are not gonna pay. Something we have to consider and think about because that causes even more distress and difficulty for people experiencing these types of things. All right, DSM-5 has its critics. We think of psychology as a whole as derived from philosophy. And which philosophers? Well, we say particularly Western philosophers, right, who were probably mostly European, right? And so they had ideas about the human mind, the brain, why we do what we do, activities, behaviors, how we think. And we say, well, interesting, how did they feel about the rest of the world? Maybe they didn't know about the rest of the world, right? So the European, we may classify them as predominantly middle-aged, white, highly educated, academic, scholarly individuals. You say, well, that could be a bias towards the rest of the world, who have different lineage, ethnic backgrounds, different ways of viewing the world, different spiritual sort of guidance, different ways of doing things, perceptions, perspectives, all sorts of things. So it has its bias, right? So we need to think about that. Reliability and validity of the DSM-5 are deficient based on empirical research, right? So we say it's just the best of what we have, but there's a lot of research out there that could contradict what the DSM-5 says about certain behaviors and modalities and disorders. But there's some discussion with issues involving the absence of viable neuroscience biomarkers for specific diagnoses and conflict of interest in pharmaceutical research. So we could say, well, interesting. We are combating and contrasting against pharmaceuticals, right? Things that can differ with changing hormones, chemical signals, chemical messengers to the brain that may say otherwise. So there may be arguments against psychologists and psychiatrists. Bless you. There may be arguments between psychiatrists and psychologists on how to aid and help someone with a behavioral trip. Because if one says, hey, we actually hooked up the brain and we put them on PET scans, CAT scans, whatever, and we've actually introduced some pharmaceuticals and these are the results of the behavioral change, and we say, hey, we don't believe in that. We think that there's a natural process of how we can reorder people physiologically or mentally. Like, well, we differ, right? One that says yes.
Kind of unrelated, but I was just curious if you have any thoughts on like the growing movement to give psychologists prescriptive authority.
I don't believe so. I think that it changes the way psychologists think about helping individuals as a whole, and I think we should divide the two. I think psychiatrists should focus on deficiencies, abnormalities in chemistry and people's brain functions, right? Hormones, all sorts of chemicals. Whereas I think that we should say, well, okay, even if there are deficiencies, to some degree, maybe the deficiencies are caused by some sort of mind state, right? Environmental issue, your impression about things, the valuation you give to things out in the world. We think that we can maybe solve it holistically. So maybe ours is more of a holistic approach as opposed to, say, altering physical chemistry, which is just completely different, right? Because we're talking about chemistry, and I think they're completely different things. Like we say psychology, we think psychiatry more would be related to engineering and sciences. Ours is more related to philosophy, to be quite honest. Where psychology is more related to the ideas about the human being and the process. Understanding a little bit of the scientific functions of how it all works, but using the mind as a problem solver for everything physical, right? That where psychiatrists or those in pharmaceuticals who say using chemistry to solve immediate problems. But you say, what's the pros and cons? Both. We know that if you alter chemistry, ultimately you alter something else too, right? There's no way of introducing anything that says nothing else could go wrong. Never heard of that medication in my life, right? But we say there's usually another cause and effect, always takes shape. And with us, you say, well, what if there is a genetic issue? I don't know if the mind itself can solve a predisposition or genetic abnormality at birth. I don't know if we can help with that situation. So nothing comes in a perfect bubble, flaws to both. But I think if you blur the lines, then you start to lose shift and focus on both sides. And I don't think that's good. I think sort of keeping defining borders allows for people to focus more on an objective, specific objective. And ours is not dealing with chemicals, right? That's just not what we're trying to do. All right, so those arguments, good. These are all theories, and you have to think about the body of knowledge is always limited until someone thinks of something new, right? Which is why you're in school for. You think of that. In essence, you're in school to increase the body of knowledge. If not, you'd be like, hey, I regurgitated all this information, but I contributed nothing, right? The people we read about here in parentheses are people who've contributed something, a theory, an idea. And although we may say like, oh, they're completely wrong, or completely disagree, that sounds stupid. We could say that, but you have to have an opposing hypothesis and something put out there. Hence, creative writing might be good. Writing some books about ideas about psychology. Maybe you blur, maybe you merge the two. Creative writing and psychology. Right? Think of some new wonderful ideas, theories. All right. All right, other critics of the DSM-5 argue that it relies too much on the medical model of mental disorders, which presumes that a mental disorder is manifest as a disease or illness within a person, and does not give adequate consideration to environmental factors. This is a good critique. Think of that, a good critique. If we say we're taking a medical model, and you come and approach me and say, hey, I have some behavioral issues, if I'm taking the approach of a medical model, first thing I'm saying is, hey, I think you have a mental disease or a mental illness. You would say, well, that's very limiting. You didn't even consider that I'm a human being walking around in environments. And we know at the cellular level, regardless of what the brain says or communicates, the body says, I don't care. I have automatic processes to adapt to environments. That's what evolution does, right? So we said we have microevolution. If you move to Miami, stay there for a couple of years, things will begin to change, whether you like it or not. What do you think about it, right? You move to some island, things begin to change at the micro level, right? All sorts of things. Protein to be built more, get more sunlight, right? Hormones begin to change. There's stuff that you can't do nothing about. So we say environment is important, extremely important. And maybe what anyone is going through could possibly link to the environment, right? So we say change the environment, change the person. But if we take a medical model approach, we say, no, hey, yeah, it's just you. It's not the environment. No matter where you are, you just have a mental illness. And that could not be the case, right? Good theories, good arguments. So in layman's sort of speak, in lay speak, in common speak, we say, hey, you are who you are, irregardless of where you go, right? You go move to Switzerland tomorrow, you're still you. That's very limiting too. Because maybe you don't become you. Maybe you become a different person to a degree, by changing your environment, right? So how do we know this is true? Usually when we look outside, we say people are a product of their environment, right? Right now, why is some people are more inclined to commit crime? Maybe their environment, crime is a part of survival. That's not it's not your environment, right? Maybe you would be the same exact person. So we can think like, oh man, it's horrible. These people are just bad. Think of that approach. The approach, we look at somebody, we like, you're just bad. You have a mental illness. You commit crime. You do horrible things. You are so argumentative. You're aggressive. You're violent. It's just you. Another approach could be like, it really sucks you to be conditioned by that environment to make you into you. Right? Two different approaches. Which one is perfect? None of them are. But we do have to consider multitudes of perspectives when we look at these things. All right, psychiatric labels can have consequences that are harmful. Labels communicate to the client and others that the client's situation is hopeless when labels lead to social stigmatization. Huge. I had a sister who was schizophrenic, right? And when she was like formally diagnosed, it was just a label that kind of stuck around forever, right? She passed away. But you did notice the shift in even how family members begin to treat this individual, ostracize, stigmatize, talk about them behind their back, because the label reinforces, it gives you an identity, a new identity. You're no longer a man, now you are a man with schizophrenia, right? You're a schizophrenic guy. Like, whoa, that goes with you along the way. It becomes part of what you're known for, right? It follows you as a reputation in some degree. You're like, well, that impacts you. That makes the situation worse. If the labels are really reinforced socially and they're strong, now you say, I'm hopeless. Why? Because the doctor said I have this issue. The doctor knows best. DSM-5 said it. And we say it makes you more hopeless. So labels are bad. And we know this just outside of psychology. Labels are bad regardless. They divide people. Black, white, Asian, Catholic, atheist. You immediately feel feelings about people. Immediately. Something pops into the mind. It's automatic process, right? Automatic process of how we see people. You're like, oh, you're different. You're like, different how? You have to be different because you're this. Right? We take away the humanity. We take away the commonality. Now we focus on the differences. Instead of just saying, oh man, you're a guy like me. You're a human being. Hey, what's up? What's going on? How's it going? You know, blah, blah, blah. Now you become all this other stuff. Now we got to focus on all that. Really, it probably doesn't matter. You're just a human being, changing environments, different ideas, and that's that. So it can make things a little bit worse for people, depending on how they see it, right? But everyone is strong enough mentally to disregard the labels and move through life as just a human being. Some social workers have maintained that it's not only is it possible to help people without using mental illness label, it is perhaps preferable. For clients with the same diagnosis can exhibit different maladaptive behaviors. Diagnostic labels can establish or reinforce a client's belief or fear they have permanent pathological conditions that cannot be altered. You change the impression about how someone feels about their condition or their experience for that matter. Although diagnostic labels may communicate standardized information, especially to professionals from other disciplines, here Cutchins and Kurtz argued that what is communicated is not necessarily client's best interest, truthful or reliable. We say it's limited, and we should also inform our clients that the information is limited, right? We should give them the appropriate communication of information. Here we got some proposed an alternative classification system for problems in social functioning, but this system was not adopted by mental health professionals. More recent alternatives have been offered. Here, Garland and Howard in 2014 espoused a trans-diagnostic perspective that addresses common processes, right? Underlying psychological suffering and distress, thought suppression, memory bias. So we could think of more of the processes as opposed to giving a broad defining label. We can more focus on processes such as memory bias, thought suppression, and psychological suffering and distress. We can spread it out to say, like, you're just going through psychological suffering or distress, and you're having these processes associated to such, as opposed to you have general anxiety disorder. Others have advocated behavioral change approaches that focus on the function of problem behaviors or functional assessment analysis rather than diagnosis. So here we're saying, hey, remember we weren't reimbursed by insurance companies for functional assessment analysis. Maybe that should really be the focus. Maybe we should just address each individual case by case through an assessment or analysis rather than a sort of long-term or permanent mental health diagnosis. All right, some repercussions. Practitioners recognize that diagnosis is not the same as behavioral assessment. Although it might be necessary for insurance reimbursement to give a client a DSM-5 diagnosis, it's more important that the practitioners conduct an assessment to arrive at a justifiable basis for intervention plan. Instead of resulting in diagnostic labels, behavioral assessment is part of a problem-solving process that leads to the target behavior. So maybe we should just be looking at targeted behaviors, controlling antecedents and consequences, rather than meeting the criteria for a label that comes from a disorder diagnosis. All right, cultural diversity and cultural competency, right? This has become a big one. Now, everyone is discussing mental health, who prior decades did not discover it because of the communities which they come from. The religious backgrounds they're affiliated with, the cultures that they're associated with, the practices, traditions, and values and norms within those cultures. Things are beginning to get a little bit more fluid. People are opening up to more medical professional help and information about mental health. So we say now things are different, but there's still some biases, right? So we got increased diversity, right? And this has become prominent for mental health professionals. So we want to be competent and culturally competent about diverse perspectives. Increased diversity in U.S. and elsewhere has required changes to the healthcare system, particularly mental health care system, to promote cultural competency and to meet the very needs of multicultural populations. These changes have been prompted by findings of certain cultural ethnic minority groups, such as Asian Americans, who have underused medical services. So when we say in the past, Asian Americans didn't use a lot of mental health services. Mental health services have not been accessible, available, or effectively provided to African Americans, American Indian, right? Alaska Natives, Asian American, Hispanic, and LGBTQ population for a host of reasons. One could be financial, two could be just a cultural perspective. Maybe they don't believe in those things or they view it in a negative way, right? They're viewed in a negative way to have a mental health label, a disorder. Maybe people fear it. They don't want to be in that community and people feel a certain way about them if they have these labels, right? Or other restrictions. Maybe some of the practitioners, the psychologists, weren't working with those groups. Their focus was people who look like them and have the money to attain their services. They say it's been very sort of biased and discriminatory within this field, and now it's beginning to change somewhat. All right, so cultural diversity, environmental supports and stressors for these populations may be culturally determined, such as housing, lack of employment opportunity, incidents of discrimination. One of the most interesting things you think of like racism. Part of my research in South Africa dealt with how racism and ethnic discrimination stemming from apartheid leads to not only mental health issues, right, all sorts of disorders, but physiological. How does racism cause diabetes? How does racism, ethnic discrimination cause high blood pressure, hypertension? Right? And you say, what's the association? What's the link? Well, if you experience release of cortisol, stress hormones for a prolonged period of time because you constantly can't find a job because the social system you live in don't want to give you a job, right? Financial strains if you have a relationship and can't find a job because the system doesn't allow you to really have an adequate job, right? They're gonna give it to different group of people who looks more like the people who have the power dynamics in that community, right? Or the political power. And you're like, well, what does that do, right? How does that mindset create long-term impacts on the physiological aspect of a human being? Well, we say we can associate those. And now we have a host of issues stemming from some social issues, environmental stressors. Lastly, cultural competence has been conceptualized within a framework that focuses on 3 practitioner characteristics: attitudes, awareness of one's personal behavioral change in the human services, biases, and cultural assumptions; 2, knowledge, non-judgmental understanding of people's cultural perspectives and expectations; and 3, skills, intervention techniques that are culturally sensitive and responsive to diverse clients. Culturally competent. Be aware of one's cultures. Ask questions. What's important within your culture? What do they value within your culture? What are your spiritual perspectives, right? Non-judgmental. Yes, we have our Western approaches, but we know they're limited. And then skills. What are some intervention techniques that can help this person from this particular culture? What can help an LGBTQ individual? What can help an African American individual based on their environment, their beliefs, whatever is valued in that community that they come from? What can help a very religious individual if spirituality is a component of them during therapy? Maybe part of therapy is a spiritual component. And if you're not well versed on that, or you don't ask the right questions to get that information, you can't help them because you have disregarded a huge component of their life. Just trying to put a medical diagnosis on top of an intricate human being who has social identity. Okay, that will be it for today. We will resume on Monday. Halloween is when? Tuesday. Anyone dressing up Monday? Clown suits? No, vampires gonna show up to class? Maybe we could dress up as a psychological disorder. Okay. So maybe someone can dress up as anxiety. I wonder what that would look like. That would be interesting. Someone would be like, hey, could you guess what I am? And I'm like, oh, general anxiety disorder. I can tell it. Yeah. All right, everyone.